everyone's okay.
Cool.
Has he just gone?
Yeah.
So professional, aren't we?
I think it could be his signal.
I'm just readmitting him now. He's coming back in.
Oh, bro.
Sorry about that. I don't know what happened. Technology, eh? Yeah, so as I was saying, my name's Ben Greenwood. I'm acting chair of Health Watch Rochdale. So we'll kick off with the agenda quickly because I've only got one item of business to do, and then it's over to Margaret. So we had a process to appoint a new permanent chair. I was only ever a temporary, and I'm really pleased to say that we the process finished and we got an excellent candidate in Margaret. But just to complete the governance, we just need the board's approval for Margaret to take over, and then I'll hand over the reins if that's okay. Yeah.
Yeah.
So all the board members are happy with that appointment? Certainly am. Okay, well that's me finished now, and I hand
Right, thanks. I'm really pleased, and it's a real privilege to be appointed as the chair. So I'm really looking forward to getting to know the role. I have been trying to get familiar with it over the last few months, but hopefully I'll settle in time and get to be the sort of chair you're looking for. But I think my first duty should be to thank Ben for the tremendous job he's been doing for the last 9 months, over 9 months, I think, in terms of actually operating as the acting chair and getting into the role. I know what his pressures have been, so I really appreciate it, and I hope everyone else would join with me in thanking him in that way.
Thank
Indeed.
you. Very kind.
Yeah. I've got to apologise before I start. I was saying earlier on, I've got a screen. I can see 4 at a time, so I'm going to be moving between screens. So if people have got anything to say, they might have to shout out to me if I miss anything along the way. So do forgive me. But if I can just open then with the first item that I've got, which is the presentation from Katie Moss. And I think she's got a colleague with her at the moment, Programme Lead for Greater Manchester Clinical Support Services Programme. Right, over to you then, Katie, if that's okay.
Thank you, Margaret. Oh, brilliant, Rob, thank you. So thank you for inviting us to present today at today's session. Obviously, I want to talk about the diagnostic collaborative networking that we're doing in Greater Manchester. So I'm Katie Moss, I'm the Programme Director for the networks, and I'm joined today by my colleague Chris.
Yeah, afternoon everyone. One or two of you may have been unfortunate enough to cross my path before. I know Simon has numerous times. Thanks for the opportunity to talk to you today. So I'm Chris Slight. I'm the Greater Manchester. I'm now the Chief Officer for the Imaging and Pathology networks. Katie's going to do all the hard work and go through the presentation this afternoon, and then we'll both be very happy to take any questions at the end. Thank you.
Let's move to the next slide, please, Rob. So on the agenda today, I'm just going to give you a summary of what you can expect from the presentation and the areas that I'm going to cover. So I'm just going to give you a brief summary of us and who we work for and what we're looking to try and achieve, what our diagnostic services mean in terms of our networks and what services are included and who are our main members. I'm going to go through our successes to date and what we've achieved, and then also outline our future plans going forward. And then I'm going to give you just a brief summary of a very fast-moving programme which is focused upon introducing community diagnostic centres across the region. Next slide, please, Rob. So as you can see, our programme's moving really fast. On the top of this slide, it just gives you an overview of Chris and I and what our backgrounds are. We have changed roles since this presentation was developed. Just very recently, we've been put into these new roles of Chris as Chief Officer and me as Programme Director. But Chris and I do have a background in diagnostics. Chris has got a very, very substantial high-level background in the operational and strategic roles within the NHS. I have come from a diagnostic laboratory background. So hopefully we've got the credentials needed for pushing forward on our networks. So who do we actually work for? We are part of the Greater Manchester Provider Federation Board, and this is a group of this partnership group, which is made up of senior executives from each of the Greater Manchester hospitals. The board was established to develop greater collaboration and system working and provide a structure really across Greater Manchester in which organisations can formalise their collective decision making. And because we are part of the Provider Federation Board, which is PFB, we operate as an independent group, so we've got no allegiances to any of the organisations other than we are hosted by Salford Royal, or the NCA now, which deals with the financial transactions of our board. So really we are here to seek the views of our hospital providers and then establish a collective GM picture, if you like, of what the priorities are for diagnostic services across the region. So in terms of what we're trying to achieve, we are to work on a national, regional and local policies. So we are looking to try and deliver the elements of the NHS long-term plan. And in addition, we're currently focused on delivering a number of recommendations that was published as part of an independent review of diagnostic services within the NHS. This report was compiled by Sir Mike Richards, and its recommendations, that report, there were quite a number of recommendations, but it was to really provide significant change and investment in diagnostic services so that we can look at how we can work differently in diagnostics, look at how we can use technology and how we can digitise some of the services, and really look at how we can address some of the key workforce challenges that we've got in terms of recruitment and retention. And all these recommendations really were aiming to increase and optimise diagnostic capacity. We're hoping to then in turn reduce waiting times for our patients and diagnostic backlogs and hopefully improve patient outcomes. But most importantly, one of the key recommendations was to establish pathology and radiology networks. And all of these things, hopefully, and the reason why we presented to you today is to show that these networks are looking to try and address variations in services to patients and the service users, so that all of our patients and service users can receive the same level of quality of diagnostic service, regardless of the type of the region that they're actually in. Next slide, please, Rob. So what do I mean by diagnostic network? So each hospital in Greater Manchester has a pathology and radiology service as part of their diagnostics provision. And the diagram there just shows you the vastness of our locality, which you'll... Sorry, Karen, I've not got any interference. Shall we carry on? Okay. Okay. So when I talk about networks, what am I actually referring to? So networks are a way for to bring together matter experts from each field to share best practice and work together to improve services. The networks are also trying to work to make sure that all our services are equitable for patients across the Greater Manchester region. And now, you know, the networks are not actually new to Greater Manchester. There has been previous attempts, I would say, at working together that haven't been as successful as we would have liked. partly because of pride of staff within their own organisation, and if you like, the organisational sovereignty that each organisation wishes to maintain. But as I've been working throughout the pandemic, it's been really a positive that's come out of that, really, is the way that the diagnostic services have been supporting each other from each of the different hospitals and providing mutual aid, which in this unprecedented time has been a real positive for Greater Manchester patients. And it's this level of networking that we'd like to build upon with our networks going forward, so each organisation can benefit from each other. Next slide, please, Rob. Sorry, I'll try and speak up. I don't know what's wrong with my sound. So this slide, it just gives you an overview of what our successes have been to date in the short time that we have been established as a network, and the impact this work has had on our patient and service users. This first column, it just details the work that we've done as a network in terms of the radiology system that we've introduced. So the Greater Manchester region was the first in the country to jointly buy a single radiology system, and this means that patients now are able to have their radiology scans shared digitally across the hospital, so there's no longer that need for sending CDs or films to another organisation. The images are available real time in all organisations, so the doctors have immediate access. We've got patients no longer need now to have repeat scans when they move between sites, because what had previously happened is that a doctor would request a new scan if they were having difficulties looking at another scan from another hospital. And so this system actually is enabling the doctors to be more efficient in their working practice, and obviously benefiting the patient a lot more because there's immediate access to the scans. What we've also done in the network is we've been quite successful for funding, achieving some national funding for home imaging workstations. And what that means for patients is that the consultants are no longer need to be on site anymore now to report the scans. They can actually do that at home if they like, which means for the first time, radiologists are able to use this technology to be more flexible in their working practice, and hopefully that will streamline the turnaround times for cancer diagnostics. And then finally, as a Greater Manchester region, we've been successful for receiving some funding nationally for the implementation of digital pathology, which has been £10 million awarded to us. Unfortunately, Greater Manchester has lagged behind in the digital pathology world, if you like, compared to other areas within the NHS. But what that means for patients is that the digital pathology will allow biopsies to be processed quicker. It will mean that they will be able to support improved cancer diagnostics, and it will mean that the doctors will be able to give second opinions, or we can have a multi-team review using the actual digital system, and it should streamline the processes in the laboratory as the scientists are actually working on these samples. Next slide, please, Rob. So our future plans for our network is to act as a collaborative influencer, if you like, and system leader for our network, with a view to try and encouraging the hospitals within Greater Manchester to work together and improve the diagnostic services across all areas of their communities. Going forward, we'd like to introduce more technology and digitisation within both radiology and pathology. And that means we are looking towards introducing artificial intelligence and machine learning, which will facilitate the existing staff and hopefully help with staff and services where there are staff shortages or lack of specialists in those areas. So it will actually support those staff going forward. We're hoping to standardise a lot of processes and systems for each of the services, so patients again will get the same level and high quality of care going forward. And then we're looking to increase our point of care testing so that patients can receive tests a lot closer to their home rather than having to come into the hospital. And we would want to try and look at pathology tracking and tracing. At the minute, there's no formal process for patients and laboratories to track samples from GP to reporting. So for us, we are looking also to increase the numbers of diagnostic staff and improve the work-life balance, if you like, for existing staff. As a region, working as a network, we're able to seek better value for money into the equipment. If we work together as a region, we can buy equipment across all of the laboratories and help build on those relationships to try and reduce the sovereignty that local diagnostic services have across Greater Manchester. Next slide, please, Rob. So first and foremost, our network priorities, one of the network priorities is to introduce community diagnostic centres, which is a new initiative of the NHS, which is looking at trying to build more capacity, diagnostic capacity in England, and move diagnostic testing away from hospitals and more into local communities. It means then patients will no longer need to have multiple appointments for diagnostics, and these all diagnostic tests can happen on a same day, one-stop shop, so patients can be diagnosed a lot quicker. And it'll stop the post-lottery inequality of patients who may receive one type of pathology or radiology in one area who may not necessarily have ease of access in another. In terms of patient experience, it will make sure that patients don't have to have multiple appointments now at different locations. It will all be in a central place, and that will therefore will help with them when they have to do their booking of appointments, because hopefully we'll try and build a system in so that patients will only have to use one booking system instead of multiple hospitals and multiple booking sites. This community diagnostic centres are being looked at, being sited in places that have got better accessibility for patients. So we've got a lot of considerations are being taking place on where they will be sited in terms of access for parking and public transport. And then because these would be a new initiative, it would bring in the opportunity to use new technology within those centres, such as virtual appointments, and help the patient manage their pathology service and results a lot better, hopefully, via the use of app-based systems. Next slide, please, Rob. So in terms of feedback and why we're presenting to the board, we're looking to try and seek the views of all our patient service users, community sectors, representative, and they're going to be crucial to the success of our programmes. I think it's fair to say that we've done we would like to do more engagement with our community sectors and service users, and work in partnership with all these bodies to understand what matters most to patients in terms of their diagnostic services across Greater Manchester. So for us, we're kind of asking the questions of how do we link in with members and the community groups? Are there any specific health advocates or advisors in the community who would be willing to help engage and shape with some of our programmes going forward? And in terms of like doing this types of presentation, what other methods would be useful that you find useful to understand what's happening in our sector and our programmes of work? Next slide, please, Rob. So that was a short and sweet presentation from me. I'm sure you've got plenty of questions, which Chris will answer. Thank you. Any questions?
Are there any questions?
Yes, Margaret.
Just one on AI. How are you going to embody it, and are you using any universities to help you embody it?
That's a really good question. So I think First of all, what I'd say about artificial intelligence is people get quite nervous about AI and it being something new. And actually, we're all exposed to AI every day. Whenever we shop in our supermarkets, most of our supermarkets that we go to regularly know what we're going to buy before we do, because they gather all that information. So artificial intelligence isn't just about diagnosing from a scan in radiology or diagnosing from an image in pathology. It can actually help in diagnostics about making sure that people are given the right appointment at the right time that they can access. There's lots of different uses of artificial intelligence. But yes, we do try and work with the universities and with academia and our partners who supply our equipment in developing artificial intelligence. It's going to be the real future for us in diagnostics. As Katie mentioned, we've got some real staffing problems, not just now, but thinking about diagnostics increases year on year. So just about every patient accessing healthcare will have some kind of diagnostic. And you hear about cancer waiting times or elective operation waiting times. All of those are influenced by diagnostics because every patient comes to diagnostics. And even if we carry on and increase workforce numbers, which we struggle to do, the workforce numbers never go up linearly with the demand on diagnostic services. So we need artificial intelligence to do things like prioritize scans reporting, and that's where the machine learning really comes in. The more information that passes through the algorithms, the more machines and artificial intelligence get used to identifying slides or images that need an earlier intervention than some of the others. But to answer your question, and it is a question, yes, we do work with suppliers, we do work with third parties, and we do work with academia as well, because that's absolutely fundamental to the future of our services.
Thank you.
Yeah.
Karen,
Sorry, just to add to that, have you thought of using AI and machine learning for training people in the new technologies, such as MRI, where you're using nanoteslas and stuff like that?
So that is yes. That will be again a fundamental contributor to training in the future. I do hear a lot of the time, to be perfectly honest, we need more people in, but we haven't got time to train them. So yes, we will certainly be looking at that.
So if you move on to the people,
thank you very much.
You're very welcome.
Can I move to Karen and then to Kate, if that's okay?
Thank you. Can you hear me?
Yes,
yeah.
No problem.
Oh, lovely. Oh, I've had a nightmare. The patient application group.
Oh, you faded out then, Karen.
You were faded out. You were doing so well.
Am I back again? No? Yes?
Yes.
I'm the chair of the Patient Advisory Group, and I volunteer as the patient voice. As a patient partner with the different providers, commissioners, with the University of Salford in training student nurses there. My perspective, I take an overall perspective, and obviously my priority is person-centred care, design, co-production. And you mentioned now you're looking for feedback at the moment and to engage with patients. And I'm just wondering, you've got to this point where we've now got a new vision for the service. Has there been any inputs to this point at all of patients' perspectives? And moving forward, how are you going to co-produce the services that you provide? Because I'm a little bit confused after hearing your presentation. How will you be processing and undertaking investigations and diagnostics from both hospital and, say, GP services? Does it cover all? And what's happening to the radiology that's currently in Rochdale? We've had a lot of change at the hospital there. We've still got a radiology department there. So what will happen with that one? Or will patients from Rochdale still use that, and will we come to diagnostic centres? Sorry, I know there's a lot in there, but I'm just wondering, how we will, be directed, if you like.
Yeah, so I'll try and answer that, Karen, and then I'm sure there's a bit to unpack there. First of all, on the patient engagement, there is not as much patient engagement as we would like, and that, if I'm putting my cards on the table, that is exactly why we're here. We really want to get patients involved, certainly around the community diagnostic centres as we start talking about pathways. Obviously, we get clinicians involved in those discussions, and we've got clinicians from primary care and secondary care and social care as well, actually involved in the community diagnostic centre programme. But we really need to get patients involvement, and that's why we're here. So really great to make the connection, Karen, and I'd like to pick up that discussion with you offline about how best we do that. I think to answer some of your other questions, we're certainly not looking to move diagnostics from one space to another. We need more diagnostics in the community. We need access for patients. One thing that COVID has taught us, and in all those benefits that Katie described, we've also managed to acquire lots and lots of equipment from the national programme for patients of Greater Manchester that patients are benefiting from. So we've got more diagnostic equipment, particularly in imaging, that's radiology, CT scanners, etc., than we've ever had. But we need to create additional capacity, and we need to create capacity closer to patients' homes, which is what we're trying to do with the CDC programme. Also, we need to make sure that patients that access secondary care have timely access to the equipment that's in secondary care as well. So when people enter the urgent care centre at Rochdale, they're not waiting behind a whole load of patients that, to be perfectly honest, do not need to be at Rochdale for their scan. They want early access to the MR or the CT that's at Rochdale. So the theory is, and the caveat to this is that there has to be funding that supports this, and even if there's funding, we need an additional workforce as well. So there are some challenges around this that I'll be perfectly upfront about. But the theory is that by providing additional diagnostics in the community, patients that need diagnostics outside of secondary care can go elsewhere for their diagnostics and have that all under one roof, hopefully. So imaging, endoscopy, cardiac monitoring, etc. That's the theory. It's all done under one roof, and that releases capacity within a secondary care environment, so that patients who need that more urgent access get more timely access to it.
Yeah.
And I'm sorry, Karen, you probably asked some more questions that I've forgotten as I've been waxing from there.
Yeah, no. You covered mainly. It's just that services have got quite complicated with all the changes. And as you know, in Rochdale, we've had a lot of change, and we either get sent to Bury or Oldham, and it does make you feel as though at one time you had a hospital, and it was your hospital. It just you were losing that personalisation and sort of a nice cohesive feeling towards your treatment. You know what I mean?
And it's a shame that I didn't bring one of my clinical colleagues here today, actually, although Katie and I are both clinical by background. We're not actually practicing clinicians at the moment. One of my neuroradiology colleagues at Salford tells a story about the day that their radiology PACS system went live. He was able to report straight away on a patient from Rochdale that had a head CT scan at Rochdale, and before this new system, that would have waited days, if not weeks, to be reported. That was able to be reported from a clinician sat in an office at Salford, and with the home report, maybe at home, wherever that might be, maybe even north of the border, reported in real time. So that real patient benefit, it might not feel that you've seen a doctor locally, but a doctor with the correct credentials and that level of expertise, you're not waiting for that access. Radiology weights broadly fall into two categories. You wait to have your scan, and then once you've had your scan, you wait for your results. The technology and the digital bits certainly speed up the second of those elements, and hopefully, as I say, with the AI, it will streamline the first element as well. So we get a large number of patients who don't attend at the moment, purely because the appointment they're given is inconvenient to them. If we can start building up artificial intelligence around that, we'll get a whole reduction of what we call do not attends, and that will give us better productivity, and ultimately that's better for patients.
You okay with that, Karen? Let's move over to Kate now for her question. Yeah. And then to Simon.
Good afternoon. I'm Kate. I'm the Chief Exec at Healthwatch Rochdale. Just a quick one. So you're talking about the diagnostic testing, and one thing that really comes to mind for me is the While You Wait program that GM are running at the moment, the comms program around the delays around some of the testing. And I was just wondering, it sounds brilliant, the figures that you're giving us and the fact that there's the really quick access that people are getting to the results, but we know there's still a massive backlog of patients that still need to be seen. How is the service looking at managing that?
So again, Kate, that's a great question. And Katie mentioned a couple of times in Mike Richards' report on recovery and renewal. So just on diagnostic waits, it's important to remember that report was commissioned pre-pandemic. There was already a real problem in diagnostic waits, and it is that demand that goes up year on year, and the fact that we're struggling with workforce. So we knew that before COVID. And then COVID hit us, and we had to put in infection prevention measures around access to scanners, etc., that have actually had a big hit on efficiency and productivity. And now we are trying to recover, and the national ask on us is to get to 120% of pre-pandemic diagnostic levels. That's what we're required to do. It is horrendously difficult. I'm not going to try and say any other than that, particularly with the new IPC measures that we're working towards. So we need to put more diagnostics in. We're trying to invest more in diagnostics. Diagnostics is certainly now more in the spotlight in terms of healthcare than it's ever been. It's recognised as a problem, but it can also be a solution. I don't think I can answer your question direct, Kate, if I'm being really honest about it, and give you an assurance that yes, it's all going to be. But we have got some green shoots with the new technology we've got, and certainly with the digital agenda. Katie talked about the PAC system, the digital pathology. We're also getting new pathology systems in. Digital and investment in digital is absolutely essential, and we've got really ambitious plans to do that. But again, Kate, if you'd like to take a discussion offline, I'd really welcome that. Hope that answers your question partly.
Thank you.
Thanks a lot, Kate. Simon, come in.
Thanks. Hi, Chris. Long time no see. Hi, Katie.
Indeed.
Too long, probably. But anyway, just diagnosis is key for elective activity. Without the diagnostics, you can't get elected. So I appreciate that. Technology, you talk a lot about, but it's an enabler. It's not a solvable thing. You still need the staff to look at it and do things with it. And given radiology is the national shortage, I mean, great ambition to do this, but I question where the staff are coming from to do it. To be honest, to be blunt, it's not just a GM system, it's a national system. Also, estate-wise, if you do community diagnostic centres, estate is a massive problem in the service, isn't it, in terms of location, etc. Rochdale Infirmary's got a good site, even though it's a hospital already, to have a diagnostic centre there, I'd argue, for the Rochdale residents. The other one is that diagnostic tests, point of care testing in primary care, where does that link into that? Because that's going to be a growing area. I mean, community diagnostics was set up for GPs to refer for diagnostics and then back to primary care. But if you do point of care testing in primary care, you don't need diagnostic centres. A lot of it can be done in primary care now. So I suppose it's that imbalance of just staffing, big one estates for me, are the key ones. How do you see GM addressing that to get to where you want to?
Yeah, so let me try and pick those up, Simon. I think there's three things there. There's the point of care, there's the workforce, and there's the estate. So I'll try and address those. And you'll have to tell me a secret. You still got your hair, and I've lost mine since we last met. But maybe that's a diagnostic program that's come back to.
We'll talk about it after.
So on the let me take the estate one first. I think the estate one is when we started looking at where to put community diagnostic centres. You can do a whole load of shape mapping tools, I'm sure you're familiar with, and all that sort of thing. We've had to triangulate our original plans, where we really wanted to site these new diagnostic centres. We had to balance that with the availability of estate and think about taxpayers' money that we're spending. And I think that the directors of strategy working with localities have done a fantastic job around that. And we've reduced our capital programme from something like 150 million requirement to 58 million, and we can still deliver that ambition. The revenue is another matter. And like you say, the question of workforce, that is undoubtedly our biggest risk about where the workforce is going to come from. And you won't be surprised to know, Simon, that we don't have the answer to that. We are discussing that with the regional team and with the national team. And there are a whole load of innovations that we're looking to support that digital enabler. And you're absolutely right, that's just an enabler. We still need pairs of hands. Of course we do. We are doing things like international recruitment. We're doing things like setting up academies, and there is an imaging academy at Rochdale that some of you may know at the infirmary that I set up about 4 years ago now. But my successors in the Northern Carolites are growing that academy. But they're not short-term fixes. There's a whole load of initiatives on the workforce front without there being one magic bullet. So we are aware of that as a risk. And then your last point about point of care and how that fits in. Again, this is where the digital connectivity fits in, because the CDCs have various what the national team call archetypes. You can have a build where everybody goes through. You can also have hub and spoke models. And when I'm talking to primary care colleagues, I'm really interested in phlebotomy. That is a specific clinical pathway that we're looking at through the program, so that all these are interlinked, and patients only need to go to even a diagnostic centre for the diagnostics, such as imaging or endoscopy, that you cannot provide at a more local level. So for me, and this is my comment, so I'll own this, the more we can do in the community, even down to GP level, or maybe even outside the traditional healthcare setting, if we can get phlebotomy departments set up and what I would call minor diagnostics, we can get patients accessing those. It's the connectivity that's important to make sure that sort of model can work. But they're the sort of things that we're looking through, and where seeing that through a patient's eyes would be really, really helpful to us. Does that answer your question, Simon?
It does, and just sorry, a final one is we probably do too many diagnostic tests in England because of risk management. People tend to want diagnostics before they make a decision or anything like that. So great having more diagnostic capability, but you may actually generate more demand than is actually necessary. So how will you manage that? Because we've seen that in the past, open new services, it's flooded, shut it, the activity disappears, somewhere else, or it just disappears. So I suppose it's managing that, we've got a new prescribing lead at NHS England to look at over-prescribing, not about cost-effective prescribing, and really diagnostics needs to be cost-effective, not over-diagnostics.
I think the only way I can really answer that question, Simon, having spent most of my life talking about inappropriate testing and initiatives to reduce unwanted demand and unwanted variation, is to make sure that these pathways are clinically led. You need people with the expertise to make sure that the clinical pathways are optimized, and that the order sets are clinically owned and clinically driven.
Thanks.
Can I just now hand over to David for I think he's raised his hand for a question, and then given the time, I'm going to have to draw it to a close after answering Karen's type question, if that's okay. Okay. David. Oh, you're on mute. You're on mute, David. Sorry.
Sorry, I'm not from the NHS, so I don't understand a lot of the jargon, I'm afraid. My question is just the same as Karen's, so I'd just like to ask it in my way, just so I can try and understand the answer. What I got from the presentation is that one hospital can now talk to another hospital. It seems quite mind-blowing to me that they can't do that prior to this. Okay, one hospital can now talk to another hospital. Can the hospital talk to a GP surgery that has got the ability to do an X-ray or not?
David, first of all, apologies if we're talking jargon. We only ever talk to one another in the NHS. Nobody else will ever listen to us. It's probably because of the jargon that we're talking.
I'm finance, so.
So apologies for that. I always say in the NHS we're talking CLAs, which is 3-letter acronyms, so that nobody else can understand us. Apologies for that. I think to your question, we need better connectivity between secondary care, that's hospitals, and primary care, which is your GP surgery. That is something that there was a national programme for IT that tried to address years ago. It had partial success, but not the success that we need. For all this to work, and certainly in pathology, results go back to GP surgeries electronically really, really quickly. I think there is some work to do within imaging yet, so that X-rays are available to GPs.
So the answer is no.
The answer isn't a direct no, because it's happening partially, but it's not as good as it could be. I'm sorry if I sound like a politician answering that question. We need to see better reports and better ways for GPs and secondary care doctors to speak to one another more timely. And with the technology that we're trying to introduce, that will help with that.
If I walk into a health centre in Rochdale that's got, not a hospital, that's got the ability to do an X-ray, are they able to send that X-ray to your network to be able to get it, somebody to look at it and send back an answer?
They will be if the technology is available to do that. So that when I talk about the PACS system, that is Patient Archive Communication System, and that is hospital jargon for, that is the system that holds the images, so it holds your X-ray. If that community diagnostic centre, and this is the plan for those centres once they're set up, if they have access to that PACS system, while you are, in theory, while you are still in that centre, that image can be taken, it can be looked at by a doctor, might be sat on a beach somewhere, and that report bounced back to the healthcare clinician that's in that diagnostic centre with you. That's the sort of that's the sort of model that we are looking at, David. Right. Does that answer your question?
It does. Thank you.
And then there was just this last point that Karen wanted to make, something about will funds be diverted from other sources? Is that what you're trying to check out, Karen? You've done it again. You're on mute.
Yeah, you mentioned that there were questions around the funding for the future, and I just wondered, is there a chance we're going to be diverting funds from existing diagnostic services? Because you said these are in addition. I'm just concerned, that in our local hospitals that they could end up being short of staff and more than they are now.
Yeah, so that is a concern, Karen, that as we expand diagnostics, we're basically fishing in the same workforce pool, even if that money becomes available. So I'll try and explain in a very simple way the difference between capital and revenue. David will know this better than I do with his finance background. But capital is your one-off expenditure. That's when you go out and buy your new car, you save up for it, and then there's a revenue bit, which is your running cost that you need for your fuel, more than you've ever needed fuel. Sorry for mentioning it. Your tax and insurance and all that sort of stuff. So those revenue challenges are significant in the system. The government have released a whole load of capital, and Greater Manchester have benefited from over 30 million for digital and potentially 58 million for the CDCs to set those community diagnostic centres up. The revenue that we're going to need to support that is still on in negotiations. Now, there are other sources of funding, such as the TIF fund and the Elective Recovery Fund. There is a national pot of revenue for CDCs, and it's 410 million, and that sounds a lot, but our current plan in Greater Manchester would cost 130 million in revenue. So there's a lot of discussions to go on yet before the funding is understood and provided. But what I can say is the government do recognise this. They're already planning to invest significantly, both in capital and in revenue. Whether it's sufficient to deliver our plans in their entirety is another question. We might have to think about how we prioritise what funding is available to meet those criteria that Katie was describing earlier. Ultimately, this is about reducing health inequalities and giving patients access to diagnostics where they need it. So they're the fundamentals that we'll work to. I can't hand on and say there will be enough money in the system. What I can absolutely say is the government have invested very, very significant figures to at least get this programme off the ground.
Thank you.
I've got to draw it to a close now. I'm conscious of the time that we've got now, but I really do appreciate the time that you put in. I'm sure all my colleagues here, you can see the level of interest that's come from the discussion today. So thank you to both of you. I'm sure there'll be more conversation along the way.
It's a pleasure, Margaret. Thank you for giving us the airtime. And if colleagues do want to answer any further questions, Katie's email address, Katie can forward them through to me. We'll get back to people with answers. Thanks, Margaret.
Thanks very much indeed. You're welcome to stay, but I'm sure you've got yours. We have to get on to our business now.
Thank you.
Will.
Thank you.
Thank you very much. Thank you.
Thanks very much. Bye.
Thanks a lot. Bye. Right, conscious. Sorry about this. Got to try and move on through the agenda. Have we got questions from the public? I don't think I've seen any.
None received.
None received.
Is everyone okay to approve the minutes from the last meeting?
Yes.
Silence of the chest, yep. And were there any matters arising that anyone had to raise at all that were on the action column? No? Right, we'll get through that bit quickly then. So there are any declarations of interest? Nope. Sorry, I keep moving through the screens. So can we move to the action log? If I recall correctly, there aren't any from the last meeting, are there? Rob? So we can smooth over that one quickly? Yep, great. So straight on to the staff presentations then, if it's okay.
Fantastic. I'm just going to open that up and I'll share my screen, hopefully. Can you all see my screen? Yeah, perfect. Good to see nodding heads. So I'm Rob Butler, the company administrator, and I'm going to quickly overview on impact and key feedback that we've received over the last quarter. So I've put numbers on there, so I'm going to work kind of clockwise. First one, I think Ben's already mentioned, it was just a congratulations to Margaret being appointed for chair of the board. Your efforts have already been noted and the positive impact that you've had with the team. Secondly, just a quick update on Hotwood Hall College. We're currently in talks regarding a work experience student who's hopefully going to be coming on board on a temporary basis with us to help enhance our social media platforms. On to point 3. Youthwatch is currently tapping into an area of service users where we've had little or no feedback previously. So we're starting to get more now, and we're enabling the youth to shape the information they receive, empowering them with useful information and signposting. Point 4, we've recently made contact with services regarding access for non-English speaking and asylum seekers requiring translation services. There was a bit of confusion over that with the services, and as a result, refresher training's been sent out, provided from the CCG, which will enable staff at local level dealing with these types of service users. On to point 5, we've had numerous positive feedback from stakeholders and Healthwatch England. Firstly, we were selected to discuss our achievements in the collection of our demographic information with Healthwatch England, because we were recognised as one of the best within our network at collecting demographic information. So thanks to Claire for that one. Our volunteer and engagement officer, Naomi, created and delivered some volunteer management training. The feedback was absolutely fantastic from Healthwatch England. They were over the moon, so much so that they're going to be using this on future training sessions. On number 6, our communications and informations coordinator shared some data with Rochdale Council regarding hospital waiting times. On follow-up with this data, it's prompted discussions, and as a result, public health funding was allocated to support those now waiting for care. We've recently embarked on a journey to attain the Investors in Diversity Award. So hopefully everyone's received an email about that. If you could take time to complete, that's just a little plug from me for that one. So hopefully this time when we next meet as a full board, we should have that accreditation, fingers crossed, all being well. The Moving On report and recommendations we produced featured in an article in the Rochdale Online. We're awaiting a formal response on the back of the Ombudsman report and a follow-up to our actions based on recommendations. Meeting date has now been set with the Chief Executive, Kate, regarding the next steps, which will be discussed at our next advisory group. And finally, we've seen a huge increase in feedback as a direct result of a collaboration between now being back out on the ground and social media efforts. It seems over the last quarter, especially over the last week, it's kind of skyrocketed. Came in over the weekend and was like, wow, I've never seen the inbox so full. So yeah, that's great news. The impact it just shows being down on the ground. How
that
much
will be the boosted post as well, Rob, on social
media. You did get a mention in there. It was. All noted. Thanks for that.
Sorry.
You're okay. So that was just a quick overview of the impacts kind of over the last quarter we've had kind of collectively and within the community. So hopefully we'll be able to talk about a lot more over the next quarter as well. So now on to key feedback. Historically, over the last kind of year, it's been mainly GPs and dentistry. Now as COVID, has started to be lifted slightly, we're starting to see different types of feedback. So we're still getting a large amount of negative feedback regarding GPs in the borough, including kind of waiting times to get through to the surgery, staff attitudes, staff training and availability of appointments on the day, and face-to-face appointments. I know a lot of surgeries now are trying to do this virtually. A lot of people do still want face-to-face appointments, which is causing a bit of a struggle. I can also report that we have received a number of positive feedback. So we've started now physically asking on engagement for positive feedback, because people are always quick to shout when things aren't going right. But obviously now we want to know what's the good, the bad, the ugly when it comes to feedback. We've had quite an increased number of cases where medication and prescriptions have been changed without consent from patients. So we've contacted the CQC, and HMRC CG are also involved, and they're dealing with the individual practices directly now as a result of us contacting them. Dentistry is still on there, one of the top ones. It doesn't appear to have progressed much at all since COVID was kind of the restrictions were lifted. We're still inundated with residents that are unable to register as an NHS patient. On the positive side now, they do seem to be letting kind of minors and the youth able to register as NHS patients. So that's some kind of glimmer of hope. We have been made aware that that dental practices have taken a zero tolerance approach to people missing appointments. So if people are missing appointments, that's literally one strike and you're out, and they won't let you back in. And finally, as hospitals are now performing more routine appointments and surgeries, we're naturally seeing a rise in feedback in this area, mainly around increased waiting times in A&E, low staffing levels whilst receiving care and treatment. So that's something that's kind of simmering away, where we seem to be getting a lot more of now. But that's my key feedback over, and I'm going to hand over to Claire.
Hi, my name's Claire Birch, and I'm the Information and Communications Coordinator at HealthWatch Rochdale. Are you doing it? Yeah, thanks. From the 1st of January to the so regarding our website sessions, we had a 49% decrease on our website sessions from the last quarter. This is probably due to previously having gone out to recruitment via for our community engagement project worker, which received a large hit of website visits over that last quarter. So we're back on average now with 2,059. We also had a decrease in users by 51%, but again, I think this was due to previous recruitment that was been on our website. We had a 17% increase though in the last quarter of how long people were staying on our website, which is always good. It means they're reading just a little bit more of our information. The top pages that people visited on our website were the home page, then the vice chair recruitment, and then, sorry, I just need to lower this, and then the feedback page, which has 156 views. So how did people come to our website? So 896 people came from organic search, which basically means that they've put a search item into our website, which could be something like how to make a complaint about GP, how to get a COVID vaccination, and our website has come up top of the list. So they've come to our website on that. 743 came direct, so they put in HealthWatch Rochdale, so their intention was to come to our website. And then we've had 368 come from social media, so 213 from Facebook, 133 from Twitter, 10 from Instagram, and 10 from LinkedIn. And we've had 52 from referral, which means they've come from another website, so another website has had our link on and they've clicked on it and come to our website via that way. Next slide, please, Rob. So these are our top tweets. So for Twitter, we had 24 new followers and we did 169 tweets. So our top tweet was the Blue Monday Wellbeing event in January, which was a Rochdale and District Mind event. And that's 1,226 people saw that. Again, in February, our top tweet was regarding Time to Talk Day, which is interesting because both of these tweets are on regarding mental health. And this had 1,109. And then in March, it was regarding findings from the Care Quality Commission. So this showed that the majority of people had a positive experience regarding maternity care, and we was asking people to share their experiences to see whether that matched the findings of the CQC. Next slide, please, Rob. So Facebook, our top posts. So in January, our top post was our staff and volunteer coffee and cake catch up. So that reached 1,477 people. In February, it was regarding, have you been to see your GP recently? So this is asking for feedback on GP services. And this is the post that I have just boosted last Thursday, which has resulted in an influx of GP feedback for Rob.
Certainly did.
And it shows it's working though. And then for March, it was regarding the Youth Watch monthly meeting. Now, this only had a 596 reach, which was quite low. But again, we have only got half of March's statistics on here. Next slide, please, Rob. So our press releases. So in January, we had 3 press releases, and one of those was published in Rochdale Online, which was regarding the appointment of our new chair of the board, Margaret.
Thank you.
In February, I also heard that this was in the Rochdale Observer as well, Margaret. In February, we had 4 press releases, and again, one of those was published on Rochdale Online. That was regarding our residents review, asking people to share their experiences of our services and how we can improve. And in March, we had 1 press release up until creating this presentation. Next slide, please. So this is our feedback, so a summary of our feedback. So as you can see there, the majority is negative. We had 15 negative pieces of feedback from 1st of January to the 16th of March. We had 9 positive, 3 mixed, 2 neutral, and 2 are unclear. So how do we get that feedback? So we got 22 pieces via our website, 2 via a third party, 19 came through the telephone, 10 came through an engagement event, and we received 14 via email. And these are the signpostings that we've done over the month. So we've done a total of 80 signpostings, and the top places that we've signposted were Rochdale Advocacy Together Hub with help regarding making a complaint. That was 22. HMR CCG with 18, and the Greater Manchester Emergency Dental Team with 6. Thank you.
I wasn't sure whether or not people wanted to ask anything as we were going along, or just wait till the end. Is that the usual way, just straight to the end? Yeah,
I don't know.
Right, fine. We're going to Naomi then.
So good afternoon, everybody. I'm Naomi Kenyon. I'm the Volunteering Involvement Officer. Next slide, please, Rob. So we've been really busy with our Youth Watch. So we're doing a lot of shouting about Youth Watch at the moment. The aim of Youth Watch is to engage the young people across the boroughs of Rochdale, ages between 13 and 18, if they live, work, study or access services in the Rochdale borough. We've had quite a good bit of involvement from young people across the borough. They participated in sharing information around Safer Internet Day. We've actually, we signed up to Safer Internet Day, so that's our little certificate at the bottom saying that we're part of that and we're promoting it. One of the main reasons around that is because our Youth Watch meetings are held via Zoom every month, the second Tuesday of every month, and that has actually been asked from the young people as a preference from what they want to meet on. They feel safer, it's easier for them to access, they're at home, you know, there's no travel involved. So it was just, you know, it's enhancing their knowledge around staying safe online and stuff. We've had a survey what ran over social media as well as through various organisations and schools, asking young people where there was gaps in information in the Rochdale borough, where they thought that things were missing.
You cut out, Naomi.
Unplug this. Can you still hear me now? Yeah. So we did a digital survey asking young people if there were gaps in information sharing in the Rochdale borough, and we're just in the middle of analysing them. but there is some very, very key topics, what a lot of young people have said: mental health and well-being, emotional well-being, money advice has come up really, really high on it as well as creativity. Young people want to know what they can do for their own well-being around dance and art and volunteering as well. Under that creativity, it's like enhancing their skills. So that's been quite interesting. So we'll be able to share the results of that soon. We've also been participating in the Raising Rochdale Send initiative, looking at how we can work better with the CCG for children's services. Our Youth Watch 100 is going nicely. We've had the survey in January, the survey in February. We had a break in March. The January one was around the COVID and flu vaccinations, and it was interesting to see the rise in the number of young people who have now taken up the COVID vaccination locally. And we also asked their opinions and feedback on having the COVID or the flu vaccination. In February, to link in with the local Greater Manchester No Place for Hate campaign, we asked young people around what they knew about hate crime, and a lot of people's responses was that they've reported it, they know people who it's affecting mental health and well-being and stuff, but they have quite a good knowledge on it, and a lot of them are telling us that it's something that Rochdale seems to be doing very well at within schools and youth groups as well, promoting the No Place for Hate campaign. So that's very positive. We've carried on doing our monthly meetings via Zoom. The attendance is very varied. I think it was January, it might have been. We got quite a lot of young people in attendance. But they, like I said before, they do prefer all to want to take part still via Zoom. So I have offered if they would like local areas, or even like the local bowling or the new golf, and they've all just said that they'd like to take part online. We are still offering the incentive that if young people take part in 5 meetings, we're giving them a voucher incentive, and it's a voucher of their choice. We have now had 3 young people who's come to 5 different events, and they've opted for vouchers for Odeon. Well, 2 have opted for Odeon, and another one opted for an Amazon voucher. So it's just a way of thanking them for taking the time to be involved with us. We have been involved with a community partnership with Fairlinch Park High School, and that's involving Rochdale Women's Welfare Association and some other local organisations, looking at how we can better work together to get youth voice heard and make sure that their feedback is coming into the different services and how we can help them better. And we've still got our recruitment pack live on our website. So it's an ongoing recruitment for our Youth Watch members. At the moment, we have got 15 members. Some young people have dropped out because of pressures of exams and stuff like that, but they still wanted to be kept on our mailing list. So that's a positive as well. Next slide, please, Rob. So some Q4 highlights. We've been very busy now that we've been able to go back out and about from like February, March. So we're still doing lots of virtual attendance, the volunteering involvement from myself. We're doing grassroots, we've been on the part of Disability Forum, we're part of Rochdale in Rainbows, the Communities and Faith Network, and we're still part of the Women's Network. We're still taking part in the Youth Watch online meetings, and the young people are really starting to open up a lot more and having a lot more open discussions, especially around healthcare, and also saying a bit more information around what they feel local is missing. So that's a real positive. I attend the Strand at Cuckle the 2nd Thursday of every month for an information, advice and signposting session, and that's at the same time it's the Rochdale Food Pantry Food Bank. So there's a lot of people who do come through the door, so it's a good way of getting our information out as well as trying to get feedback in. We attended the CRISP session for carers living with dementia, raising awareness of Health Watch Rochdale, and we had some very positive information back stating that a lot of the people who was at that had never heard of Health Watch Rochdale before, and thanked us for giving them the information, signposting to us as a service. And we've also attended the Caring and Sharing Women's Coffee Morning at the Better Together building, and that's every week for a group of ladies from all across the Rochdale borough. Some of them are refugees or people seeking asylum, and some of them are carers. So they have guest speakers, and it's just an opportunity to again raise awareness of us as an organisation. We had a lovely coffee and catch up at the barn. This was definitely the highlight of my quarter this time. It was lovely to see everybody and so nice just to be in person. And we had some absolutely gorgeous cakes. So that was definitely the highlight of this quarter for me. As you can see from the picture at the top, I had my booster vaccination at the #1 Riverside, but I also spent quite a lot of time talking to people there and giving information around Health Watch as well. So that were really good. I attended the Shamwari project at St Andrew's Church, which is a monthly drop-in for refugees and people seeking asylum run by a voluntary organisation. I think there were about 80 attendees there, families of, I think there was probably about between 18 and 20 different languages spoke there. So it was a really, really good session and got some very good feedback around health and social care locally for people who are refugees or people seeking asylum. And I also have made connections with the volunteer manager at Rochdale Infirmary to see how we can link better with our volunteers and their volunteers as well and do some collaborative work. Next slide, please, Rob. This has been another highlight of my quarter. We hosted the GM officers meeting. So bi-monthly, every different Health Watch across Greater Manchester hosts the bi-monthly meeting, and we hosted the January one. So it was very well attended. We're very fortunate to have Katie Moss, who you've just listened from, who presented to everybody on the meeting. And we had updates as well from across. We had good attendance, and it was just really nice to see everybody. So we're very impressed that we hosted that in January. Next slide, please, Rob. And here we are. This is like my favourite thing ever. This is us at the barn enjoying our coffees and cakes. So it was absolutely lovely. Our next volunteer catch up is on Zoom, and it's going to be in April. It's going to be an Easter catch up, coffee and cakes. So if you can attend, please do. Like I say, it is on Zoom, but we do encourage you wearing bunny ears or whatever, and bring your own coffee and cake as well. So we will do an Easter quiz and we'll have an update. So please do join us if you can for that. Next slide, please, Rob. And just a little bit of a quick overview of some other bits that I'm involved in with Health Watch as well. So it's the Engage project is specifically for asylum seekers and refugees, and it's looking at gaps in healthcare locally for asylum seekers and refugees. So we've done some online forums with different organisations who work with refugees and people seeking asylum. I've attended the practice managers meeting to try and get GP's perspective on where there potentially is gaps or what they do as in translation services and access when people want to register. I've attended the Shamwari, which was part of this as well. And there will be a report around this at the end of April, what's going to go out. So it's been a very interesting project, and we've included quite a lot. Well, as the months have gone on, we've found more and more local organisations who support refugees and people seeking asylum, but don't necessarily know about each other. So it's been really, really good to collaborate and connect everybody. So that's been really interesting. I've started doing a digital project with Brown Hill School, which is in Rochdale, and this is going to be sort of like looking at what I was speaking about before, the gaps in information for young people, and they're going to try and help create a wonderful leaflet that's going to be funky and enticing, and it's going to be their project. So I'm going to take ownership of it, and I'm really proud of this group of young people. With our Rochdale and Oldham Maternity Voices partnership, we have got an interview on Friday for the vice chair role, which is going to be really good. We've finished the Baby Bubbles project now, which was working with people who'd had babies in lockdown and looking at the parenting for mental health and early attachment. And there is a report what should be due out at the end of March on that. And coming up, we will be working on some racial inequalities workshops alongside Cartwheel Arts at Deeplish, working with South Asian ladies and their children and families, looking at the maternity journey in a different way, really. So it's looking at journaling it, it's looking at creating it through pictures, but also gathering really important feedback around their journeys, where there's been gaps in services, what's worked well, what's not, what could have been improved. So that's going to be really interesting as well. So we're looking forward to that. And that's it, I think. Thank you.
Now.
You're on mute, Celeste.
Can you hear me, everyone? Good
Yeah.
afternoon. Hi, my name's Celeste, and I'm the Community Engagement Project Worker at HealthWatch Rochdale. Next slide, please, Rob. My role includes planning and delivering information and signposting sessions monthly to surgeries in each of the 5 boroughs covering Haywood, Middleton, Pennines, Rochdale North and Rochdale South. I deliver monthly information and signposting engagements to gather feedback from residents. It's about getting their experiences, good or bad, positive or negative, in order to improve the services. I also do raising awareness sessions to promote the fantastic work of HealthWatch Rochdale. Some engagements during March are at the Lighthouse, which was really amazing experience, and Hare Hill, which is today. It was amazing. There was a lot. The people came more later in the day, but it was really good that they were interested in receiving some information. And the infirmary, which is due, I believe, next week. With the infirmary as well, I've actually been attended. I was invited to attend their lived experience meetings, which is monthly. And I attended my first one recently, and it was really insightful into hearing the experiences of patients at infirmary who's had experiences there. Next slide, please, Rob. Also attended op meetings, team meetings, the advisory group, which was fascinating to see, the volunteers that came together to make a difference and use that information that we collect from residents to improve the services. Also, volunteers catch up and the BAMI forum. Again, that was really insightful and very interesting to see diverse communities come together. It was really amazing to see so many areas, diverse areas of the community and different organizations as well. I also attended in March community events for International Women's Day. It was really amazing. I went to the Mind Wellbeing event. It was a cafe opening event, and the Mayor of Rochdale was there. And it was really amazing to see how much work is being done for the people of the community to help them in terms of the courses available at Mind, one-to-one session, group sessions, a lot of advice and signposting was happening for them to get help with mental health as well. It was really amazing. I also attended the Breaking Through Creative Paths to Our Freedom at Touchstones, and that was really fascinating as well, because there was lots of women there from different parts of the community, and we all got together to really talk about the things that we value in the community and what we want to see improve in the community and ideas for community cohesion. I'm due to attend the Pakistani flag raising event, and that's tomorrow. I've never attended an event like this, but this will be a really good opportunity to have the HealthWatch presence there to support the community as they commemorate Pakistani Day. And so that'll be amazing to see that. I have also been networking with other organizations and building relationships with other organizations as well, like the Caribbean and African Health Network, CAN, and also Community Arts Northwest and Community Health Champions. I've also done loads of training. I've completed, because I'm new to the role as well, so I've completed lots of training. I've done 9 HealthWatch England training sessions. I'm due to do a safeguarding session in April. Next slide, please, Rob. So this is me at the Caring and Sharing Information and Signposting. That's Nikki. She's the host of the event. So I attended the women's drop-in at the Better Together community building with Caring and Sharing, and that was on the 16th of March. Next slide, please. And this was me at the Mind Wellbeing Centre on the cafe opening day. So there I am with all the people. Then there's the mayor at the very back of the picture, you can see. Yeah, it was an amazing day. So I attended this event. It was nice to see, like I mentioned, the mayor was there as other representatives as well. I attended as part of my role as HealthWatch. Mind now have 2 community cafes, one based at Naib Van House in Rochdale, and a new wellbeing centre and cafe on Wood Street in Middleton. So you can feel free to pop in and visit and benefit from the wonderful work happening there. I believe the cafe is open for everyone. So just, feel free to go and see what it's all about. Next slide, please. So going forward, what I'm hoping to do is to deliver information and signposting sessions, to continue to do this work and to share the gathered feedback in line with policies and procedures. and also referrals for our advocacy panel as well. When people have complaints about the NHS, I refer them to our advocacy panel hub. And also to deliver raising awareness sessions. That's going to be amazing because we'll be getting a lot of influx from interested organisations. Used them through our comms. We're going to be really inviting people to, give us opportunity to raise awareness of Health Watch and the work that we do. And I'm going to be looking forward to getting more of those things booked in and events booked in for that. Also connecting more with more grassroots groups, seldom heard groups. So that's something that's on the agenda as well, to make sure that grassroots groups are involved as much as possible and also feel that their voice is being heard in terms of health and social care services and how it can improve them for them as well. To gain more knowledge about Health Watch England, to be an established community engagement project worker in a Rochdale area who people recognise. So it's really important for me that people recognise me, that recognise me in terms of my role in Health Watch, so that they know who to go to when they want to engage with, with us on our information and signposting event. So they recognise me to say, yeah, that's a person who's doing that at this particular venue. So with the information and signposting, they are weekly. I go to each surgery every week, different surgeries, and I'm looking forward to doing more of that going forward. Thank you.
Thanks for that. Is there anybody? Okay, still on the screen. Is there any comments or observations that anyone has on the papers? I am conscious I'm not doing very well at managing time, so I do apologise if that is an issue. Any? No? Well, just want to thank you again on behalf of the board. Tremendous work that you all do. It's amazing, and I really appreciate you joining us for lesson you're back getting into the role and doing the duties that we're looking towards you achieving for the future on behalf of the organisation. Thanks for everybody. Thanks very much for your input. I always look forward to those presentations. Thank you. Pete. Right. That's nice little addition.
You've got a newcomer.
Apologies about that.
Lovely. So
and I hope I don't ruin his life.
Could we move on to the next item then? Conscious of poor Karen sat there waiting as well. Karen, if you want to do your input now on the advisory group, please.
Would you like me to share the report, Karen?
No, I'll work through it.
Yeah.
1 second, I will share. There we go.
So, well, just at the top of that, I too would just like to say how good it is to see that, staff are back out there on the ground, and to see the areas that you're involved with and where we can get that information from. So that, was really good to see, like I say. I'll just have to move off my screen because it's blocking my view. Right, okay. So this is my report of the Patient Advisory Group for the last quarter from the 22nd of December to the 21st of March. I'm not sure why it's ended up like that. I think it is that we bring it right up to the date of the meetings. Again, the activity of the group is geared towards making sure that we are as effective and meaningful as we possibly can be. And members really value that we are a group of independent patient voices. But it's really rewarding to see how we are coming together in Celeste. It was lovely to hear you say that you obviously picked up on that we are managing to work effectively with staff members of Health Watch Rochdale. And obviously we're keen to sustain the existence of the group. So that's what I've been reporting on. We've had a few months of swapping and changing around, really, how often our meetings have been held, and that's coming from, in part, the involvement of the staff and their workload, and how effectively we can feed back into the group, because we have to wait when we've actioned. Some of our actions take a while to come to fruition, and we were concerned that our meetings wouldn't be meaningful if we didn't have anything to report back. And we have had conversations about concerns of loss of momentum when we went bi-monthly. So we've agreed that we are going to continue to have our monthly meetings to avoid confusion. We had confusion one month, and depending on the workload, really, we will make sure every other month is a formal meeting, and then the interceding months we will hold development sessions, but may well also be formal meetings if needed. We also have looked at our monthly feedback report. One of our members mentioned that she wanted to know a little bit more about what was behind the statistics. And so after conversation, and Claire very kindly came and discussed it with us and showed us some of the raw data. And it was really interesting to see, what was behind those statistics, and has offered for us to have sight of those if we feel it's necessary. But we've continued to continue with that current format, but just to be more detailed, more specific really in what the themes of those complaints are. I think one was under well-being, for example, and it could have been more specific about what that area was behind well-being, just so that we keep on top of the trends of the information that's coming to us. I was concerned that the action log, because we're very keen to track all the information that's coming into us, our feedback. We don't want to lose any of it. We're very keen to make sure that we retain credibility with our members, and also, wider in our public. So we don't want to lose it, but it was becoming a little bit difficult to follow sometimes. So we're hoping that we'll be able to make sure that the more active issues that we've got are going to be more visible at the beginning of the action group. Our You Said We Did partnership approach is very important to us, that we are seen to do actions. We don't want to become a talking shop, that we make sure that we can action feedback. And we've recognised there's a lot of changes that have happened across all our providers, the CCG, and this actually, naturally has an impact on how effective we can be in trying to develop those connections with those different organisations. We appreciate it's the long game that we're playing here, but part of the, for example, the work plan for post-COVID recovery. One of the things was to make sure that we did have, co-production in the reset, the Build Back Better in the organisations across our health services, and Health Watch Rochdale wanted to make sure that that was happening. So we've had conversations about how we're going to make sure that that does happen, and that patients are being involved and carers are being involved in those rebuilding activities. Yep, I think I've covered that. The decision-making chart that we had, I'm just going back there, Rob. We've looked at the escalation policy, decision-making policy in our flow chart, which we've been refining. One of the comments was, the colours that we use, our brand colours, did tend to confuse it sometimes. So I think we're looking at how we can simplify that just to make it look more obvious and simple. When you actually drill down into it, it does, but we're just concerned that that might look too confusing for some members. So we've agreed to look at that. I think we can move on. I met with our new chair, Margaret, and I personally felt it was a very positive meeting with Margaret. We discussed the aims of the group, our future plans, and how we can work together collaboratively to make sure that we do get that meaningful work that members are looking for from the group. So we look forward to working with you, Margaret. So moving on to development undertaken with the group, we've tried to put speakers into place in our development sessions, and we've had a I'm losing my train of thought. Helen Chico came to speak to us, the prevention lead for Rochdale Council, about the prevention strategy, which was very interesting, and she provided follow-up papers for us to go away and think about that, because there was a lot of information in there, but it was a really good presentation, and she's opened the floor, so to speak, for us to go back with more questions after. We're waiting for the EIA training to be arranged. There's been documents shared with members of the group to help them understand the approach that we're taking here at Healthwatch Rochdale. And in that, I mean that we're looking at what is influencing the way that we have to plan working with other organisations to be able to create those meaningful connections and processes, hopefully, that are now being encouraged by national papers. So hopefully, now that patient engagement and quality improvement strategies involving patients are on the national agenda, that will really support our cause here. I've included there that it's important that Healthwatch staff have offered to support our bi-monthly development sessions. We're waiting for the badges, I think. I don't know if they've been given to members, but that was ongoing for us, as was the acronym Buster, to help newer members. And you know, some of these acronyms, they're confusing. There's new ones popping up all the time, so we just want to keep abreast of those so that members understand. Recruitment, as always, that's ongoing. One of the things that we were discussing is that we don't want new members to feel frightened off in a way, because obviously some of our meetings for members that have been with us for a while, and some of the conversations that we have could sound a little off-putting, because, well, you know, because of some of the acronyms alone and the language that we use. And everybody gets involved at their own level. So although we have the roles and responsibilities that members have, we don't want it to be daunting, because there's so much valuable information and skills that, you know, that we can benefit from, but from people working at different levels. We have mentioned a buddying system so that new members could buddy with someone. We need to perhaps pursue that, so that we do retain. We're very lucky that we have retained quite a few core members that have been with us for a while, but it's good to see new faces coming along as well. And as I say, it is an ongoing process. Just back down, that's it. Just back down again there, Rob. That's it, promotional engagement. I mentioned that it was good to see the staff getting back on the ground, and some members of the group are reporting that they're managing to get back out on the ground, but again, a lot of it is still virtual, and work that I'm doing certainly is still mainly virtual. And you do miss, you know, being able to meet up with your peers, fellow patient involvement, patient participants. It does tend to make you feel a little bit removed as patients, because obviously you're trying to work with organisations and do it in a meaningful way, and those relationships are so important, and it's quite difficult to develop them, you know, through a virtual screen. So just a few examples of the good work that's been done there. The NCA Lived Experience Panel, good work's going on there. And again, the working relationships are developing there, after saying that, but they are. And although it's a newish panel, very definitely the members with their experiences are providing a lot of valuable work with the organisation, and the organisation is very responsive, and everybody sort of feels on the same page, if you know what I mean. We're all moving forward in the same way, which is really good to experience. Better Health for Middleton, the good work done there by one of our members. If we could replicate that model, I think, across Rochdale, that would be fantastic, because that does sort of bring together patients and carers and some of the professionals, healthcare professionals. The good work with bridging communities there in the community by our member Chav. Very important work he's doing in the community. The co-production collaborative, that's something I linked with. They hold meetings. It's like a coffee morning kind of thing, and it's nice because you're able to speak openly and share your experiences of trying to do meaningful co-production with organisations. So it works as a support group, but also it provides information. So it's a really good organisation to be connected with. University of Salford Carers, that's had a real hiatus in involvement because of the COVID restrictions, but we've just had one of our first meetings, and it feels as though that's getting back on track again with involvement, especially in the the undergraduate curriculum, the work that that's being co-produced. And year one we were very involved, but unfortunately year 2 and 3 we've not been as involved with, and that's been a concern. So we're hoping to get that back on track. And yes, unfortunately PPGs are still not yet back to normal activity. I've got a little note about that further down. Connectivity, that important thing that we're trying to do to make sure that our feedback is actioned. I think it's safe to say that we're still experiencing the frustrations that we have been doing, and it does feel as though this is part of the long game. We, as I've said, have experienced a lot of changes in healthcare and the governance, and we're waiting to find out what the new main meetings are, and groups that we need to be trying to engage with. That means that we can fulfil our aims. Can we move on there? Rob, thanks. I attended the People and Communities Framework workshop. I don't know if anybody else from Healthwatch Rochdale was there, but it was a really interesting meeting, and it's held by the Greater Manchester ICS partnership. That's being formed, I got the impression. It's being formed at the moment, and they wanted to look at how we can effectively engage. And it was interesting, the discussions around the different levels of engagement and involvement, and the understanding about how that could work in quality improvement structures. And I mentioned Healthwatch and how we can be a really important stakeholder in that, and that seemed to be really well received. And I got the impression that they were really looking for those key patient groups, patient and carer groups, for that important feedback. So hopefully we'll be able to make some headway as that progresses, and I fully intend to continue to be involved with that group. We're still waiting for our meeting to be arranged with the LCO, with Kate and myself, to discuss how Healthwatch Rochdale can work with the LCO. I attended a meeting with Kate with Phil Burton to look at the PPGs. We do get a lot of feedback, as you've seen, from GP's practices, and the PPGs prior to COVID were really important. We had about 11 active out of 33 surgeries, and we were looking as a locality PPG group to look at how we could develop that further. But unfortunately, it's looking as though we're going to be starting from scratch. So Phil Burton's gone away to look at what activity there is and then how we can move forward, and we fully intend to be part of that. After, I don't know if it was the last one or the previous one, we had a presentation by Sandra Crowsdale, Director of Integrated Systems Development, and unfortunately my tech let me down. So I forwarded some questions that I wasn't able to ask at the time, and they were relating to the involvement of patients, what co-production had happened so far, because it's so important that that patient voice is central, really, to the understanding where you're getting budgetary boundaries created in these new changes, and just to be able to have the voice present when conversations are happening around how these services are all going to be, you know, the multi-provider structures now that healthcare is being delivered with. So just wanted to make sure that we could meet with Sandra to follow up on her answers, because there was one area that I wanted to discuss further, which was the Patient and Public Engagement Committee at the CCG, and her suggestion that that had provided the engagement necessary in the development of the LCO to some degree. My concern is that there hasn't been a strong patient and carer voice in that group, and to look at ways that we can improve how our voice is going to be involved. So thank you. Moving, current issues, not finished yet. So our current issues, I'm sure everybody's aware of the moving on service. We are waiting for a reply. It says their request to be sent, but actually we're waiting for a reply because there's concerns among users that we haven't had sufficient information about what that new service is going to look like and when it's going to open. GP services, those issues remain. The effect of COVID on services. It was interesting seeing the numbers there in the chat from yourself, Simon, about access to face-to-face appointments. Many patients still are concerned about that, and the appointment waiting times. The GP website reviews that Healthwatch Rochdale were undertaking, the work that we were going to do through the workshops didn't happen because it was cancelled. So we're looking at how that is going to proceed. It's important work that, as a member of the PPG, I think it would be really useful in how we see patients working with the surgeries. The waiting times, just moving on to Healy Surgery. We're still waiting for feedback there from CQC. Can you move up there for me, Rob, please? Some things here that we're waiting responses on. The Safe Haven service at Rochdale Infirmary. I attended the opening of that as a governor of Pennine Care. I'm just, surprised to see that that's no longer operating at the hours that it started at. So we'll see what the response is from that. Dentistry, the ongoing issue that was mentioned earlier. The ear care service, we're waiting an update regarding changes to the new service model. Same with autism services. Our pharmacy and minor ailment services, we're trying to arrange a meeting with Ricky Smeaton, the Senior Responsible Officer, to discuss there's several issues that are ongoing, as well as the minor ailment services that we've mentioned there. I've put on there positive feedback because we've had a discussion around how important it is for the group if we can share the positive feedback that comes into Healthwatch Rochdale. That would be a positive way to engage with our providers, the CCG, in developing those working relationships and connections that are so important. And it's obviously important for patients that where we get examples of good practice that is shared. Could you just move up there for me, Rob, please? The COVID recovery plan I mentioned earlier. But what we wanted to do was make sure that work plans are being updated to members in the data feedback reports. so we don't lose those activities. And that where I thought I was before, we're at the end of my report. Is there any questions?
I find, Karen, there's a lot of information there that you provided to us, and it's a lot to take in, and it's very much a reflection of the hard work and enthusiasm and commitment of all of you in there. You've certainly raised a number of issues and things that we need to be thinking about for the future, and I'm glad to see that you've recorded them in that way, so that we can actually see that they're going to be addressed as we're going forward. But if there's any way we can engage with that and support you through that, please make sure we're kept informed or linked to in some way. And certainly I'm looking forward to going to a future meeting to get to know you, the members of the group, as we're going forward.
I mean, I've chosen to lay the report out as it is, so that we don't lose sight of those key sort of pieces of work and the actions that were taken. If you find you want a more simple report, that's fine. I just wanted to make sure that we included everything there for you.
And it's very much what we want to do. I think it's just the agenda's got so long today, it's just got a bit out of control in terms of timescales. But other than that, I'm sure I'll have to improve my chairing as I'm going forward to make sure that doesn't happen again. Right.
Okay.
That's absolutely more reflection of that than anything that you're saying.
Thank you.
Right, should we move to the next agenda item then, if everyone's okay? The stakeholder, 360 stakeholder.
Do you want me to share that on screen, or?
Conscious of of time, Margaret, do you want me to take the report as read from board members and just go through a couple of highlights within the report rather than?
I would. It's a pity because it is such a good feedback that we've had, and it's a really good report and presentation. But I think with time, I think we've got to be realistic. I appreciate you saying that, Kate. Thank you.
Yeah, no problem. So if you don't share it, Rob, I'm just going to go off my screen. So on our 360 residents review this year, we've had 72 responses, which was compared to 5 last year. So as a whole, straight away, the fact that we've got so many responses this year is a really positive. So the information that's come out around various questions that we've asked key areas about engagement and how we can do better at that, communication, information, advice, and how we can improve there, and on impact and how we update people on the impact that we're doing as an organisation. As a whole, it was quite a split survey response in regards to people strongly agreeing, and then not knowing at all or not being able to comment. Of the people that responded to the survey, the demographic information was that 88% were white British. So that is an area that we need to look at, making sure that we're entering our grassroots for these surveys. Obviously this year for this one, we wasn't on the ground straight away for it, but next year we hope to be able to get on the ground to deliver on some of these. 74% of respondents were female, 80% were white British. We had a split various across the borough, 41% being mostly from Rochdale North. We heard from various ages across the borough, from 13 years old up to 80, which is really positive. And of the respondents, 38% of them considered themselves to be a carer. So we put an action plan together, which is just for the board to know and hold to account on. There's 3 actions in regards to the resident survey. So the first one is to create a communications campaign, which highlights Health Watch Rochdale's statutory powers, so that everyone's got a full understanding of what our statutory powers are and what we're commissioned to deliver in line with the Care Act by Rochdale Council. Raise awareness of our branding, and that's something that we as a comms team we're continually doing, looking at our website hits and seeing how we can improve things there. And then we want to get back on the ground in regards to distributing our leaflets across the Rochdale Borough. And again, that'll increase in our branding awareness as well. Sorry, there was a couple more. The other ones were to create posters to identify how people can give feedback, what can be done with.
You're frozen.
And greater quarter impact reports to let people know what we're doing. So that was just a quick overview of.
You okay, Kate?
Sorry, my video has just gone. I went unstable. So that was a quick overview of the residents. So the idea is basically we need to bump up and try and get the voice out there in regards to Healthwatch Rochdale, raise awareness of our branding and get back on the ground. And that's exactly what we've started to do. And we've started to see the increase in feedback there straight away. Really positive in regards to numbers. So quickly onto the stakeholder side of the survey. Again, a lot more responses this year, which was really positive. Key findings that came out of the report were similar to residents, really, people being aware of us, but not always 100% sure on our statutory functions, on how to contact us. So that's something that we're going to work on with professionals. We're going to get business cards sent over to various teams, virtual business cards, so that they know how to contact us. There's a stakeholder referral process that's going to be implemented from April, so that organisations can refer citizens into us to gather feedback or give them various options of how to give feedback. And there's going to be various stakeholder and team meeting engagement, which I'm going to be doing at a strategic level across the borough to try and raise awareness of what we're doing as an organisation, how we can better share data analysis and just have a better understanding of our statutory functions within the health and social care settings across the borough. Thank you, Margaret.
Thanks for that, Kate. Has anybody got any questions or observations that you want to make about that? Not seeing anything at the moment. I appreciate you going through that in such a fast way, but it doesn't represent, obviously, it's important information to be sharing generally. Can I assume it's going to go on the website and your presentation?
Yes, we can get that put on there, Margaret. Yeah, definitely.
Thank you. I'd like other people to see that information and reference it in that way. I'm sure the rest of the board do as well. So if we can move on to the next item then, thanks for that. And onto the business plan, please. External business plan.
Again, due to time and Margaret, I'm going to take the business plan as read.
Yep.
And I'm seeking board approval for this as a final plan for this next financial year of 22-23.
So I'm getting nods from those that I can see, but not everybody, but I'm assuming silence means assent. All right, thanks very much. Yeah, we've got a thumbs up from them. We're okay. Thanks a lot. So have we got any other business at all? No. So in that case, we'll draw the meeting to a close, and thanks everyone for their patience. Being a big agenda, but lots of good things coming through in the meeting. Thanks very much indeed. Should we give 5 minutes break before the next meeting? Yeah. I'm getting nods. Thanks a lot. I'm going to get a
Thank you.
Thank you.
Thanks, everyone.
Thanks, everyone.
Bye.
Thank you. Bye.
Thanks, Karen.